Good morning, everybody. As Brian said, my name is Ciara and I'm working just up the road here in St James's Hospital as a clinical nurse specialist. I just want to start off by thanking Sharon and Brian and everyone at Overcare for having me here today. And also to thank Sarah on her fantastic story. It was really inspirational. So I'm just here today just to talk about our role, particularly looking after the patient with ovarian cancer. And I don't know if anybody here has met me before. Hopefully somebody knows my face. So just starting off with just a couple of facts about ovarian cancer. The National Cancer Registry of Ireland states that ovarian cancer is the 6th most common cancer diagnosed in women, and that's in Ireland between 1994 and 2010. As Sarah had said, the average number of new cases of ovarian cancer in Ireland per year is 345. There's a risk of ladies developing ovarian cancer is about 1 in 70. And as many people here today know, that many cases of ovarian cancer present at a late stage when the disease is at an advanced stage. I'm sure a lot of people here today can relate to the symptoms up here of ovarian cancer, and I suppose that's the unfortunate thing, that why people present so late is that the symptoms are so vague and they're always put down maybe to something else first. I've met so many patients that have come saying that they have been told they've had irritable bowel or something like that before a diagnosis has been made. So I'm sure a lot of people can relate to these symptoms, some if all. And just carrying on from that, we know that the pelvis kind of has the capacity to support a lot, and women in particular, their bodies are made for pregnancy, so there's a lot of space that these tumours can take up before they're detected, and the presenting symptoms therefore are vague, and that's what causes the delay in the diagnosis for some people. And it usually only becomes apparent when it does compress the other structures around it, or a development of this fluid, the acidic fluid, grows in the abdomen. So maybe a lot of people can relate to how their diagnosis came about. I'm sure they attended their doctor first and underwent a full kind of medical history and physical examination. You may have been sent then for ultrasounds, CT scans. Maybe some people have had a biopsy taken somewhere along their abdomen, or some fluid taken off if their tummies were big with the ascitic fluid. Maybe at that stage then you were referred on to a gynaecologist specialising in oncology. And from there your case would have been discussed at the multidisciplinary team meeting. And from then on, the treatment plan then made specific to yourself. And as many of you know, then the main modalities of treatment for ovarian cancer are chemotherapy and surgery, with radiotherapy having a limited role in the treatment. This is just a couple of, well, more than a couple of people that are involved in either the care or diagnosis, treatment of your ovarian cancer. So a lot of you will have met a gynae-oncology surgeon, would have met your medical oncologist, not so much to a lesser extent your radiation oncologist. Your histopathologist then are the ones working in the lab, working on giving us the grade and the type of cancer, of ovarian cancer it is. Radiologists then are the guys that are taking your scans. This is us in the middle here, hopefully in the middle, working alongside everybody. I know some people may have needed the services of the psychological oncology team just to deal with their diagnosis. Social worker for various reasons. Sometimes the stoma nurse is needed to come in. I don't know, maybe some people here today can relate to having needed surgery that involved having a colostomy formed because of their disease. Dietitian then, just to optimise your nutritional status to bring you forward for your treatment, and psychosexual counsellor as well, just to, you know, maybe to help people deal with the impact that the ovarian cancer will have on them. This slide is just to kind of show that, I suppose, nearly like Sarah said, maybe once you hear the word cancer, there's probably very little else you hear in terms of how your treatment is going to go or what treatment you're going to have. I suppose all you can hear is this word and how it's going to impact on you and your family and your friends and your whole life in general. And it's I suppose we can relate to it, not understand as Ciara has, as Ciara said, unless you go through it, but relate to that this is all people here, and it's very hard to take in all the information that's being thrown at them. So just what kind of a definition of what I do and what all the clinical nurse specialists in oncology do. So we kind of are defined as a nurse who has expert knowledge, skills and experience within the specific area of clinical nursing practice. The clinical nurse specialist will need to have completed education relevant to the area of specialist practice, and that their aim then is to deliver an advanced level of care to include symptom management, education for the patient, support for the patient and some psychological care for the patient and their family. The origins of our role, it's been kind of long recognised in the USA. They kind of developed their role in the 1960s. The UK took on this role in the 1980s. Ireland are a little bit further behind, and they, in 2001, there was a framework developed that kind of recognised the fundamentals and the roles for the clinical nurse specialist. To date, there's approximately 370 specialist cancer nursing posts that have been approved in Ireland. So we know from dealing with patients day in, day out, that all aspects of life has changed, and I think Ciara probably described that very well in her own experience. Physically, there's a big change to your physical appearance. The loss of hair is a huge factor and will probably be a constant reminder of the disease. If you're going for surgery, then you have, the scars are there. Emotionally, relationships change, and your whole outlook on life is obviously changed, and you can all probably relate to how you felt when you heard those words. Sexually, it affects your relationship, how you are how you feel as a woman. Your relationship with your partners changes for very many reasons. Spiritually, I suppose there is a lot of why me, and deep believers that have a lot of faith there. It's probably put an awful lot to the test at this time. Financially, then obviously cancer has a huge impact on people who are, like Ciara was, working full time, families to support, and a lot of financial commitments. Your role within the family may change. I know certainly my mother is the boss of our family and the organiser of everything and the main communicator, and I suppose an illness like this, when you're taken away from your day-to-day activities and you have a lot of commitments with treatment and stuff, it's going to change your role within the family. And then you've your own personal fears about survivorship versus the fear of recurrence of the cancer. So there was a couple of studies just done just to evaluate, I suppose, our worth within cancer care, and the SCAPE project undertook a study to evaluate the CNS role, and they did show that there was evidence of improved adherence to treatment, that patients did, I suppose, just with that extra bit of contact with the hospital, were a lot more compliant with their treatment. They'd have an increased knowledge base. It did help prevent complications. I suppose our role is an advisory role and an education role, and we're there just to advise. It's somebody just to pick up the phone and ask the simplest of questions. Our role involves a lot of health promotion, advice on diet, on exercise, psychological wellness. Again, it's just maybe 10 minutes or so phone call just to kind of reassure and to help people, just on the simplest of queries to get through what they're going through at that time. Advocacy, again, we are. I'll talk about that a bit later on. But these points are just kind of what they found. The worth of the clinical nurse specialist role was. Again, this study was done here in Dublin. And these three themes emerged from the patients' questionnaires, that the patients felt that the clinical nurse specialists knew about the treatments, they knew more about the treatments, and they were willing to explain it. They were able to speak in simple terms. I know some people talk to their consultants, and there's words used that maybe they don't understand and they don't want to ask at the time, and you know, it's good for us to kind of pick it up at the end and just try and explain it as simply as people can understand it, and support, that they felt that they were always present and there. So really what we do is we kind of help coordinate the treatment, and that would mean just try and, you know, make your treatment more accessible, make the dates available for scans, for procedures, try and arrange all of that so that it suits you and it's done within an appropriate time frame. Supporting individual coping strategies, promoting social support networks, provide emotional support both for the patient and for the family, because we are aware that, you know, it does have a huge impact on partners and children and whoever is the closest person in your life, who generally comes along to their appointments with the patient, and we can build up a relationship with them as well. Advice and reassurance, always, you know, at the end of the phone just to advise and help if there's anything that's you know, treatment related or anything else, and just to be a knowledgeable resource regarding your illness. So again, just acting as patient advocate. Sometimes we get phone calls on any number of topics that people are kind of worried about or concerned about. We can take these to the consultant or whoever is the relevant person, and just kind of try and sort through these problems for the patients. Discuss their social concerns, as I said, maybe losing your job or leaving your job or taking you know, a financial hit because of your illness is a huge problem and a huge concern for a lot of people. They may be the only people earning in their house, and it is a huge concern. So we just try and help them, point them in the right direction, refer them, as the other slide had, the social worker, refer them there, and get them through as best we can. To monitor the treatment pathway, discuss the effects of treatments on the body. There are so many effects of the treatments that they have on, that is on an individual person. The physical effects are probably, you know, the ones that everybody can see, the hair loss, and you know, if people are suffering from the side effects of chemotherapy, be it neuralgia or anything like that, that's the first thing that people probably notice when you're going through your treatment, and it's what people can pick up on, and that's quite tough. The sexual effects, as we say, you know, the post-surgery, how chemotherapy affects your body. People sometimes are afraid to have sex in between their chemotherapy, after surgery, and how that affects their relationships with their partners. And we hope to just be the link between hospital and home. When people are gone home after their surgery, when people are waiting for their next treatment, there's always some concern, or, you know, they just have some question, something has happened. We're just that link to get them in if they need to be seen a little bit earlier, and then just someone to listen. I've kind of talked about this, the psychological impact, and although, as Sarah said, unless you go through it yourself, you're not going to fully appreciate it. But I suppose meeting people on a day-to-day and week-to-week basis that are going through this, you do get a better understanding of how people are feeling, and you know, what is more important to them. And certainly, you know, younger people feel that you know, their whole loss of fertility is a huge thing. Going through a treatment-induced menopause can really have a huge impact on how people feel, and things like this are kind of constant reminders that they're going through the disease they're going through, and that's a really tough cross to bear. And we hope to just try and help them along in some way to get through with their treatment. There's a lot of common questions and fears that we hear from people. People a lot of times think that it's their fault that they have cancer, that they've caused it, that they shouldn't have done this or they should have done that, they should have lived a healthier lifestyle, and they are deeply guilty that they have brought this to their family. Another source of guilt is, am I responsible for putting my family at greater risk of developing a cancer? There's been a lot in the media lately of these the BRCA mutations, and celebrities that have discovered they have the BRCA mutation and they're going for these surgeries. And people worry that they have this gene and could it be passed on to other people because they are the ones that have the cancer. Am I going to die is a huge question that is so common that people ask, and it's a very relevant question. And it's a very tough question when people ask that, but you know, we take a reassuring role in trying to help people, you know, understand that the treatments are there, and people like Ciara are a testament to how good these treatments work. Huge fear is, will the cancer come back? And I'm sure everybody in the room that has successfully got through treatment lives day to day with that fear. A lot of people take on internet searches and come up with a lot of inappropriate and inaccurate information. So we're just trying to, you know, talk to people and try and kind of allay the fears that sometimes the internet brings. A lot of people are interested in research and clinical trials and how they go about being involved in these. That's quite a common question. I suppose once people are diagnosed with this, they like to maybe see that this is kind of a way that they can help other people if they know it won't benefit them, but I think a lot of people are quite willing to give to benefit other people in the future. Complementary therapies, they're becoming more increasingly more widespread, and more people are more interested in that, and we'd always offer some advice or maybe point people in the right direction on that. Special diets, I suppose people are kind of more health conscious and are wondering, is there anything that they should be eating that will help in their treatment? And it's all these kind of questions that I suppose maybe seem silly to them, or maybe they're embarrassed to ask the doctor, or embarrassed to say in front of a large group of people, but sometimes on a one-to-one conversation they can ask these questions to us. As I said, the menopause that's treatment induced is a hard experience to go through for a lot of people, and they find that their symptoms are hard to take on top of going through the treatment as well. It's an awful lot for people to take on, so we're just here to listen and to answer questions and to advise as best we can. A lot of people are wondering how they break the news to their children, and we try and work through that with them. And I suppose it always depends on what age the child is, but we would say that the best option a lot of the times would be to be honest with the children and explain it to them in terms that they will understand. Body image as well. People have a lot of people come to us talking a lot about how they feel less of a woman because their fertility is gone or their hair is gone, and it's a huge hill for them to get over through their treatment. People are always worried about how they're going to be followed up after their treatment. You know, in terms of CA125 monitoring, how they come back to the clinic, any little ache or pain, there's always a fear that it is the cancer coming back, and you know, it's just trying to talk people through that and reassure them when they do have these fears. Losing their job, you know, taking that kind of independence away, you know, they're just trying to get through day-to-day aspects and worrying about, will their job still be there, can they go back to work, when they can go back to work, and as we said, the loss of fertility. There are just a couple of the support resources that are just so hugely important for people that are going through ovarian cancer, and hopefully a lot of you here today have availed of these services and got something out of them and made the most of them, because that's certainly what they're there for. They were just a couple of, I hope, inspirational quotes that I found, and I know I was recently talking to a lady who just felt that she told me that she didn't want the cancer to define who she was, and she just didn't want to always just be known as somebody who has cancer. So hopefully a lot of you here don't feel like that, and I hope days like this are a great support to people to help you get through it. So I suppose it's just really about taking one day at a time and you know, getting through one treatment and the next treatment, and keeping yourself well and keeping in touch with people like us that can offer the support when needed. And that's it. Thank you.